I'm going to go ahead and start. Looks like we're about 68 people online. Thank you again, everybody, for joining us today. This is going to be the last session of day 2 of the Global MedTech Regulatory Trends True Quality Summit series. If you missed the previous MDSAP sessions or any sessions yesterday, you can watch the recordings on demand. We're excited to have you join us for this presentation, The Global Guide to Human Factors and Usability Engineering. This session is going to run about 35 minutes with 10 minutes allotted for questions at the end. If any questions come up through the presentation, feel free to put it in the chat on the right-hand side, and we'll get to as many as possible. At the end of this session, remember to log into Greenlight Guru Academy, and you're going to receive your certificate for attending today's virtual event. So today we have Bryant Foster. So I'm going to go ahead and pop this over and let Brian tell you a little bit about himself and his experience.
Awesome. Thank you. Well, I'm very glad to be here. Appreciative of the opportunity to present some thoughts that I've had. And, I looked at this title here and actually was thinking that should really be, the global guide to human factors for regulated medical devices, right? It's not necessarily for everything, but this is specific to regulations around medical products. So a little bit about me. I am a co-founder of Research Collective. We started this in 2013. And I've performed, successful. I mean, I really never had anything that hasn't, been successful whether it's been submitted, to in the US or Europe, for several devices, all types of devices, and I'm incredibly grateful. I'm proud to have gotten to work with so many different types of products, and even more specifically, the people who use those products. That's one of the things I love most about what we do in human factors is that we get to work with cool products, but then we get to see who actually uses them and who gets the benefit of them, whether they're a medical professional or a patient with a debilitating illness. It's really fun to see their reactions to some of these new products that you all or other people are creating. I'm a co-author of a book called Humanizing Healthcare. It's Human Factors for Medical Device Design. We released that in 2021. And then I've contributed to another book called Design for Health, Applications of Human Factors, published in 2020. I'm also an instructor for the Regulatory Affairs Professional Society, RAPS, and I teach, of course, human factors and design controls, and have done several things now with Greenlight Guru, podcasts, webinars, classes. Okay, so jumping right in here, time is always the issue with these. I try to go short and they go long. Should I check out this chat here? Let's see. Okay, there we go. So global players. All right, let's start with, now I got to click back in, there we go. Pretty much everywhere in the world, we've got the international standard IEC 62366-1, released in 2015 and amended in 2020. And that is the application of usability engineering to medical devices. Most of us here are familiar with that document, and like I said, that is what you would want to apply if you were, launching for sale a product in most places in the world. If you are launching specifically in the US, you would be referring to the guidance document applying human factors and usability engineering to medical devices. That was published in 2016. In the UK now, we have guidance on applying human factors to medical devices. And China is set to release an HFE, human factors engineering guideline, still in draft form. Oops. So a little bit about these documents, and this is what I've kind of come to over the last few years, is that they've ended up becoming a little bit like what you might see with scripture. This is my weird, maybe it might be a weird analogy, but I see people becoming a bit fanatical about some of the specific details of the different documents. And what I would argue is that they all are saying essentially the same thing. but in different ways. And the reason they're saying the same thing is because they all are referring to a human-centered design process that was around well before these documents were drafted and finalized. And so the components of that human-centered design process is kind of immutable. And like scripture, the general tenets of the different religious areas, they're roughly the same. You treat people well, you're honest, you try to be a good person, and that's the same. And then the different differences might be related sometimes to where they're written for the population that it's written for and the time period that it's written. And so I would say I really like to think of this more holistically than getting focused and kind of hooked around the axle of the individual components of each document. But I would say, just like a religion, if you were going to try to subscribe to one religion, you would be wise to adopt their text and say, okay, if I'm going to be a part of this particular faith, they use these scriptures. You would read those and you would apply those things, because there are some differences. And that's the same here too. If you're going to launch a product in the US, well, you might as well use the human factors guidance from the FDA. And because there are some things there that you'll just want to make sure you're aligning with. Okay, so some global definitions, and in 2022, there's one in particular that we can talk about that is the same everywhere now, and it's very nice. So the first is the field of human factors usability engineering. This really is the application of human behavior, abilities, limitations to the design of products, in our case, to medical products. And we're applying the knowledge of these people so that we can design the interface so that it can be used safely and effectively by them. Usability testing is a method that we use to evaluate the product's usability. And it usually, it kind of always employs a simulated use method where we give the product to the person, we allow them to use it, and that provides us with objective evidence of whether or not it is usable, as opposed to letting them look at it and then, or letting them use it, not observing, and then asking them questions like, was it usable? Because why rely on their self-report when we can actually observe them and know whether it's usable or not based on their performance? Next, we have validation and summative usability testing. So this is the usability test that is performed at the end of the device development process, and it provides us with objective evidence that the use-related risk, or at least we hope it provides objective evidence that the use-related risk has been reduced to acceptable levels. And lastly, critical task, which is a task that, if performed incorrectly or not at all, could lead to serious harm to the patient or to the user. And harm includes compromised medical care or delay in therapy in some cases. And this is one that has been kind of, now all the documents that I mentioned before use this term to differentiate tasks that are, have safety implications and those that don't. And it really is, the FDA coined this back with their launch of the guidance in 2016. And it really has been, as a practitioner, a good way to look at all of the device tasks and be able to set a threshold to say, well, these tasks, taking it out of the box. If someone doesn't take it out of the box right, there's no safety risk there. And so we're not as concerned with that as we are the task of, them administering the medication, for example. And so it gives us a way to say, these ones are really important, and these ones are less important when it comes to safety. And so the ones that are really important, we have to provide objective evidence through our usability study that the users can perform those appropriately. I see a question here. All right, yeah, just I think it's fine, just jump in with questions anytime. You type them right in there. So the question is, for which medical devices is a summative evaluation mandatory? It's a great question. We're going to answer that more as we go along, but essentially it's any device that has serious harm related to misuse. So if you go through the tasks that users have to perform with the product and you identify tasks that if the user performs them incorrectly could lead to a harm that would be considered serious, which is subjective and up for interpretation. But if you've identified that there is some use-related harm of a serious nature, then regulators will want to see that you have put this through the proper methods, doing a summative usability study to then show that that use-related harm that you've identified is not realized when it's in the hands of the users.
Just kind of asking a little bit more around that. So this summative evaluation can be in the form of a protocol then. So this is part of the testing that you're doing sort of at the end for the validation?
Certainly. So the summative evaluation would have a protocol written to define how we are going to perform the study, like who's going to be in the study, as far as participants, how we're going to evaluate the tasks that we've identified as critical tasks. And then that protocol is executed in the usability study. And the result of that would be the report that says, okay, we ran this study with these participants in this way, and these are the results that we got from that study.
Awesome, thank you.
Mm-hmm. Okay, so just a quick, well, not too quick, but I guess a touch on the updates. So the biggest update is this amendment in 2020 to IEC 62366. And in the amendment itself, it says there were 22 issues that were presented to the National Committee. And I love this. No fundamental changes to the usability engineering process are presented or written in this new amendment. And that is not surprising one bit, and I don't think it should be, because what could really change? The process is the process. And so the changes are more along the lines of definitions, clarifications that I will talk about here. So one clarification is that manufacturers, well, and I guess in 2015, there was no ISO 14971 that was released in 2019. And so now in 2020, they said, hey, make sure that you're following the ISO standard 14971 version 2019. Pretty straightforward. As I mentioned before, the introduction of the term critical task, aligning with FDA. And I think this came from, like I said, a lot of practitioners who said this method of identifying tasks that we're calling critical, and that's a really nice way of defining what matters for the usability testing, and maybe those things that can be left or don't matter as much. There's clarification on user groups as subsets of users that are differentiated by factors that may influence their interaction with a medical device. So this is not new to 62366, but it's just a bit of a clarification that when you're looking at who your intended users are, you're going to want to look at things like, their professional background. Are they a patient or a clinician? What is their age, and how might that affect the use of the device, and so on. There's a little bit more mapping around normal versus abnormal use. A lot of times people will ask when they come to me, like, okay, how far do we have to go with looking at the foreseeable misuse of the product, right? Like if we make an injection device that it's obviously supposed to go in someone's stomach, let's say, but they're using it as a toothpick, is that something that we have to try to design for? And the answer is, no. And I think this clarifies that there are some things that would be considered just straight abnormal use or intentional misuse. And that is covered by 14971 when it talks about risk. But as far as the design of the product and how people interact with it and how you design your instructions, unless your instructions make it look like someone should put this thing in their mouth instead of in their stomach, you should be okay.
I was going to say, I have that same question often come up about risk, right? Because it's like, how far do you go?
Mm-hmm.
You can have you give it to somebody like me who's never used this medical device, and yeah, I can do all sorts of wrong with it, but there is some understanding at the level of training that your users have, right? So you kind of have to build that into it.
Absolutely. Next, introduction of training as a third priority control measure. So just like your labeling, instructions for use, training is a part of the user interface. This isn't new, again, but just it adds that clarification. Further clarification of the summative evaluation requirements related to participants, study environment, and task success criteria. So, explicitly states how participants in the summative evaluation should represent or that they do represent the intended user profiles, describing how the test environment and conditions of use adequately represent the intended use environment, and then defining correct use for each hazard use scenario. And so essentially saying, hey, their success criteria, right? In turning it on, that implies they're doing this and that. Using it, it's that. And so there's success criteria where we can say they either did it or they didn't. Kind of that 1-0 binary, yes, success or fail. And the last is a clarification that the purpose of the summative evaluation is to gather these objective evidence, or this objective evidence that the residual use related risk is acceptable. And so with the added requirement for defining what is correct use for each task or each scenario, it means that success or failure of the summative evaluation is directly measured by what is observed in the summative study. So if you get failures, that could be a failure of the study or those tasks. That is cleared up by this. A couple questions here.
Yeah, I can read those if you want me to. It looks like Dr. Ayman Eshra has asked, what do you mean by mapping the normal versus abnormal use?
So basically there's a distinction between, so abnormal use, it says, hey, that's 14,971, not related to 62366. Normal use then has kind of correct use and misuse, right? And then, so what we're doing when we're designing the product is we're trying to get as much correct use out of the users as possible through the design of the device and the instructions and the training and all of that. And as opposed to trying to prevent them from doing something that would be considered abnormal.
Okay.
Next question, how can usability evaluation be done for medical software which can be used in different medical devices with different GUIs? What would be the best approach? Again, here, this would be, if you have different graphical user interfaces, it's looking at all of the potential tasks that users are going to complete, assigning or identifying where the misuse could occur and what the potential harm of those misuse scenarios would be, and then determining, okay, do we need to put this in a formative or in a formal usability study to demonstrate that these misuse scenarios do not occur.
Did you want to keep going through these, or do you want to wait till the end to answer some of these questions?
I think I'll keep going with the slides for now. Maybe we'll come back to some of these, and maybe some will be answered by upcoming slides.
Yeah.
But maybe I'll leave for you, Nikki, to kind of keep an eye on those and put them in when you feel appropriate. All right. Additional updates. This will go pretty quickly. There's not many. So FDA, again, the guidance published in 2016, no formal updates. Although since that 2016 date, there have been, I would say, thousands of submissions and thousands of instances of feedback from the reviewers, from the FDA Human Factors Group at FDA, from the Human Factors Review Group at FDA, but no formal updates to the document. UK MHRA, that was published in 2017, and it was updated in 2021. Nothing substantial, only to reflect the end of the Brexit transition period, and then changes in reference to legislation and introduction of the new UK CA mark. And then in China, again, not finalized, but a couple things we do know about it is that they are recommending 20 participants per user group in the summative study. That is different than what the FDA recommends, as 15 being the minimum. And that the Center for Medical Device Evaluation at China NMPA prefers the report to be from a state-owned lab. So this visual here is to show the process that we're going to want to follow when applying human factors or human-centered design to the design of any product, and in our case, medical products. And I'm going to step through each one of these. And what's great is that this is, we can call it global. It doesn't matter where you're making your product or where you're going to sell your product. This process applies to all. So for all, we want to identify the users, their abilities and limitations, their characteristics that would indicate where separate user groups might be based on age, education, their medical condition, experience, and potentially how they interact with the device. So this might not be the best picture, but let's say this device here in the picture is a medical professional teaching a child who's now going to go home and give these injections, or this isn't an injection necessarily, but give injections by himself. And so, the medical professional uses the device and the child does as well. They're, very different in terms of knowledge, experience, and where they're using the device. And so all those things would be considered when looking at who uses the product and then taking that into account when making design decisions. Similar to the users, where they use the device matters. So things like lighting, space, is it a clinical environment or home environment? What are the other noises involved? So those things should be considered and put into the process as you're developing the design of the product. Identifying all of the user interface components. This gets important because I think a lot of times people think of perhaps just the graphical user interface or the buttons on the device as the interface, but it is everything that the user comes in contact with. So packaging, a helpline that might be available to the people to call and ask for help, instructional videos, all of those things are a part of the user interface that should be considered and would be subject to review or scrutiny when you are providing usability results. Identification of known use-related issues. This is a time where any reviewer would want to see that you have done your homework, that you aren't just putting forth a product that has similar issues, use-related issues that might exist in other products, and a simple search in your own product history or other devices that might be similar could identify and allow you to design around those or mitigate those design issues. The identification of critical tasks, as we've talked about, so identifying which tasks have the serious harm associated with them if they are performed incorrectly, and then that would be required to have objective evidence through a summative usability study. All right, so that's kind of the introduction. We're identifying things, we're putting all of that information that we're identifying into the design of the product. And then once we have product, some type of prototypes, we can then start to evaluate the design of those prototypes or the elements of the user interface through formative research. And a lot of times people think of formative research in medical device as being some sort of, as being a bit more formal than I would recommend. I think this can be as quick and dirty as works for you, and maybe increasing in formality and rigor as the device becomes more developed. So when it's in the beginning, you might have pictures, drawings of the product, and you can put that in front of people, and it doesn't have to be formal, it doesn't have to be actual users, and it could be something that gets the design evaluated by people to move the design forward, to keep it going in the right direction and making sure that it's usable. But if you get to the point where you're saying, okay, we're doing a formative usability study to evaluate the design of the product, then you would want to do that maybe with 5 to 7 participants. That's usually sufficient to get meaningful usability data. And yeah, as I mentioned, there's no regulatory requirements for these formative studies. You're not going to be judged on how you perform them. They're not going to give you feedback on, a lot of times people will be concerned that if something in a formative study suggests that the design should change, that if they don't make that change, they're going to be penalized for that. And that really is not the case. So I think these studies should be used for the company or for the manufacturer's benefit to get to a good product rather than thinking about how these would be regulated.
I was going to say, I think that was the question I had, and a question we have here is you had said earlier that China was kind of looking at, saying 20 participants, and I know in the FDA guidance it says shoot for 15,
Yep.
but is there a minimal number of participants required for the US and EU, or is, like you said, it's suggested but not necessarily a requirement?
Yeah, great question. So there's a distinction here, and I'm getting to now validation usability testing or summative usability testing. So the formative is what we do as we're designing the product. It's an iterative process. We evaluate and make improvements, and evaluate and make improvements. And again, there are no rules around that. Have at it. Make it meaningful, useful for you. It's this final validation or summative usability study where there's a requirement around the number of participants. And so here that we have the final design of the device, right? Like, so we wouldn't want to use a prototype that has an interface element that might be different than what the final device will have, because then we're not testing the thing that people are actually going to have in the real world, right? So having the final device is important here. Packaging, training needs to be finalized, the instructions finalized. Everything that is going to go into the market needs to be ready for this summative or validation usability study. And I call it summative or validation because 62366 and FDA human factors guidance use those two terms. They mean the same thing. So I might just go with validation usability testing from here on out, but it's summative as well, it means the same thing. It's that final summative, that final usability study where you're putting, in some ways you're kind of putting your ass on the line. You're saying, this is our product, this is what we built, this is it, this is going to go to the market, and here are the objective results from this usability study. Let me see if I can step through a couple more of these. So as we mentioned, the critical tasks need to be evaluated through simulated use. So that means we're not going to have someone perform surgery on a real person. We're not there yet with the product, but we're going to simulate that. We're going to give them some sort of model and let them set it up and use it as if it was a real procedure, and we're scoring them on the tasks, determining if they're performing those steps as intended by the manufacturer. And we're going to record any instances of misuse, lovingly called use errors, any difficulties and close calls. So, let's say they start to do something, they go down a path, and then the very last second, they turn back and they go, that's actually not what I'm supposed to do. That's what we consider a close call. They almost made a mistake, and then they maybe could have. We want to know why. And so we want to determine the potential root causes of those errors, those difficulties, and those should be linked to the design of the device. A lot of times I'll see root causes in a usability study results that say, well, the participant wasn't paying attention, they didn't read this thing. And it's like, well, we expect people to not pay attention. We expect people to not read things. What can we do as a manufacturer of the device? We can't change the people, we can change our device though, right? And so is there something that we can do through design to make something unskippable, right? Or unmissable, or come out as being, oh, I got to pay attention to this. So anyway, that's something that the root causes should link to the device as much as possible, as opposed to the people in the study themselves. And this is lastly, the very bottom, 15 per group, maybe. It could be more, it could be less. Like again, for FDA, 15 is the minimum that they say, and that usually is sufficient. But for EU, or if you're complying with 62366, 15 has become kind of the accepted norm, but it's not specified in there. So I often tell people, if you have a justification for going for fewer participants, you're welcome to do that. So I just wanted to point to the process again, and I just kind of marvel at its simplicity, right? Identifying who uses the product, where they use it, performing formative research to determine is the product usable along the way, and then finally validating it through validation and usability study. A handful of questions. I want to go through this last slide. It's kind of, but we're doing, I think, pretty good on time here. Okay, so I want to talk about elements of the human factors reports and their priority. And this comes from years of experience, reviews from reviews that we've gotten back from various reviewers, notified bodies, FDA. And so I'm going to build out this table. And what's nice, so we're going to talk about the elements that every human factors report is going to need to have regardless of the market, then the priority given by reviewers to that element, and then my notes on why that priority assignment is given. So the first is every product, every submission related to usability is going to need to have a description of the intended users, uses, environments, and training. And that is a low priority given by reviewers, and I agree. And essentially, you just need to follow the guidance or the guideline that you're working with and provide that information. Again, those characteristics of who uses the product and identifying any potential differences that would cause them to be different user groups, identifying the environments in which they use the product. So if you stick with just providing what you need to identify, you're going to be fine there. Next, description of the device user interface. This one is also low. And again, if you follow the guideline, if you can describe what the device is, how the users interact with it, you're going to be just fine. Next would be a summary of known use related issues. And this I've given a medium. Again, I think here, they want to see that you've done your homework. They want to see that you've taken things into account, that just some simple searching around would yield some information that you could use to design your device better and avoid mistakes that are out there in the market. I think of this like when my kids come to me and ask for help with their homework, and first thing I want to ask is like, well, did you look at the book? Because I'm sure it's there somewhere, and I don't want to have to give you information that you could find yourself. And next would be an analysis and assignment of severity of potential harm of misuse, also known as a use-related risk analysis often, or a use FMEA. High, we got our first high here. And this is high because every device task must be documented along with the potential ways it could be used or misused and the severity of potential harm related to that misuse. This, back to that very first question, this is what every product needs. And this will make it very clear to everybody, or it should, whether or not usability data are required for that product. We can go down every task and identify how users might perform those tasks incorrectly, and then what the potential harm is if they do those things incorrectly. We will see that some tasks might have harm related to them if they're not done correctly, that would then require us to provide objective evidence that they can actually do those tasks without incurring that harm, right? And having that harm occur. So this is where it pretty much starts when it comes to determining what your summative usability study might need to look like. The next would be a summary of formative studies and resulting design improvements. And based on what we talked about earlier, you might not be surprised, this would be considered a low priority. Now, again, when I say low priority, it doesn't mean you don't need to have it. All of these things are going to need to be in there. But again, the results of your formative research is a nice to have, and they're going to like to see that in there to say, hey, you've done your due diligence. You didn't just throw something at the wall and now you're trying to get it through our submission process. You've worked through it and you've made improvements to the design. And so you should provide a brief summary of how you evaluated the device along the way to develop something that you're proud of and that really would be safe in the hands of real people. Next, we've got tasks that are determined to be critical and that will be evaluated in the validation usability study. So this would be a subset of the tasks that come from 2 rows above, where we say, okay, this is all the tasks, and we've got these ones that are related to safety, serious harm potentially. We're calling these critical tasks, and we're going to show you in this row what they are. And this is high, right? You've got to have this, and they're going to scrutinize it as well. They're going to look back at your analysis of all the tasks, and they might say, hey, you have that task up there that you know, that severity of potential harm, we don't agree with. We think that actually should be higher, and we think that should be a critical task. And so that these two things together will be reviewed. So again, yeah, this is very important. They're going to determine if the threshold that you set to determine what is critical is appropriate. And in my experience, usually that's somewhere around the middle of the company's severity scale. So when you look at a scale, it might be 5-point scale. Usually a 3, 4, and 5, those are going to be like of the severity that would put them into this critical task category. Next would be the details of the validation usability study. So the participants that you're having in your study, the study environment you're going with, how you're evaluating critical tasks, and potentially the training that people might receive. This, again, is a high priority for reviewers because they want to ensure that the way your study is designed, including the characteristics of the study participants and the way they simulate interaction with the device, matches the description that you wrote, saying who your intended users are, the intended uses, the environments of use, and the training is. So they want to make sure that the study and the way you're running that study matches what you said up at the very beginning as to who uses the product, where they use it, how they use it. Next would be a detailed description of observed use errors. Okay, so now we've actually conducted the study. We now have detailed results of the observed use errors, difficulties, potentially close calls on our critical tasks. And this is a high priority. It's what it's all about. This is what it all comes down to. We did all this stuff up above to get to the point where we can run a study to provide objective evidence that it can be used appropriately, safely. So these objective results should speak for themselves and should make it obvious to anyone who cares to read it, whether or not the device can be used safely. And I think a lot of times people get this mixed up with some of the other things. They think, well, if we can provide a lot of background on how we design the device, or if we can, you know, talk about how certain things aren't that important, that maybe the results aren't as important. This is what reviewers care about. The whole reason we do usability testing is to provide these objective results that say, yes, they can use it, or no, they can't. This is what it comes down to. In the report as well, though, you'll have a discussion of the acceptability of your results, and also known as, you know, you're defending the reduction of use-related residual risk to acceptable levels. So you're defending that your product is safe. And I give this a medium priority. And, you know, I think they're going to read it, but ultimately they're going to determine if your rationale that you've written here is appropriate based on the actual results above. So, you know, the actions and the results of the study speak louder than any words you put in here about, you know, how risk has been reduced. And lastly, a conclusion. And anyone who, you know, comes from FDA world knows that the conclusion in their report is the first section, but these are not necessarily in that order. But yeah, the conclusion is a low priority. Again, reviewers are way more interested in the detailed results than a conclusion that you've written, right? Because you can really say anything you want, but the results are kind of the main event here. I'll leave that on. Sometimes I guess these slides are all out on there, so you have access to those. But with that, I will ask if there's any questions. I see a few of them in there, so I'll leave it up to you, Nikki.
Yeah, it looks like we have about 10 questions right now, and I'm just going to read them in the order that they came in. So the first one we got is, can we use the risk-benefit ratio in this case? And I think that was talking about towards the beginning, so it might be a little bit out of context at this point, and was asking for an example.
So yeah, so the risk-benefit analysis and write-up is incredibly important because every medical device exists because it has some benefit, and we do accept some risk that comes along with using it, right? And so I think that's an important thing to know, is that you don't have to have perfect usability results. When I say the results should speak for themselves, it doesn't mean they have to be perfect. It just means that they have to be good enough where you say, hey, we know that there's these potential issues, but man, the benefit of using this product outweighs, right, those potential risks. And I think a lot of times people will put that on the reviewers to say, hey, they kind of throw it out there and say, yeah, I hope you agree with this. But ultimately, we as the practitioners, the manufacturers, the makers of the products need to also feel good about that and say, yeah, these issues do exist, but man, the benefit is so great that we have to live with some of these things that we might not just be able to design out. It just might have to be part of the product.
Yeah, this might lead into this as well. And I think I had probably the same question talking about sort of participants in the studies. Is there an industry standard for acceptance? When we are doing verification studies, we want to do 95, 95. It didn't sound like there was any kind of statistical acceptance for this. It's just a recommendation on participants.
Yeah, so that is a great point. When we look at the results themselves, so we have success criteria at a task level. So a task will either be passed or failed by the participants, by them performing it, incorrectly or correctly. And then down the line, we'll say, okay, did that task over those 15 participants, how many times was it performed correctly? How many times was it performed incorrectly? And for any time that it was performed incorrectly, what was the root cause, right? What in the design either kind of allowed that to happen, made it happen? And so there isn't a way to say, okay, if 95% of our participants pass this task, we consider this a passing result. That's not the case. The reviewers are going to look at each one and say, okay, on this task, we see that you had 2 people out of the 15 make this error, but the severity of potential harm on this task is so great, we can't let you proceed with that, because that's only 15 people. You can think if you throw this out to 15,000, how many times you might see that. So again, even though it's a critical task, there is a difference in in severity of potential harm. Some might be death as a result, and others might be, a delay in therapy. And so they're going to look at all of that together and say, you can have some issues that go through and it's like, okay, the issue, even though it's not that big a deal, it can exist. Others, it's like, no way, one error, we can't have that. You got to, revise the device. And what I like to point out too is that usability studies are really not pass-fail in their entirety, right? You would say at a task level, you might have failed a task. And so if you did have to revise the interface, you would need to reevaluate that particular task, that particular component of the interface that changed. But anything that doesn't change after that performed well, you wouldn't have to go do again. So your secondary usability study, if you had to do one, could be limited to just those things that have changed and be much smaller in scope.
Yeah, so not so much performance related in sense that we're kind of used to, but more tied to those risks.
Yes,
Awesome.
tied to risk always.
Yeah, and so I just kind of jumped down to try to keep this sort of same line of questioning. And again, talking about those sample sizes, somebody said if one is following the FDA guidance document, and if there are 2 user groups, would 15 users be sufficient, or would 30 users need to be? So I'm thinking, are they saying, does it need to be 15 and 15, or can it be a cumulative 15 between the groups?
So that's always a question, and the reviewers are keen to weigh in on that. And I've done it a number of ways. The cleanest way to do it, if you want to go by the book, safest approach, setting yourself up for likely acceptance of what you decided to do, it's best to keep them as separate groups, 15 and 15. If you want to be a little bit more, take on a little bit more risk and say, hey, we want to consider this one group, we're going to do, 7 and 8, or maybe even say we'll do 10 and 10, right, to go with 20. So you don't have 15 of either one, but you kind of have a little bit more larger sample. It's possible that what they're going to always want to look at though is what are those characteristics, differences between the groups large enough to say these people are so dissimilar that they can't be considered the same group, or if the tasks they complete are so dissimilar that they wouldn't consider them the same group. So like doctors and nurses, in some devices they might perform the exact same tasks. In others, they might perform different tasks. And so you'd say it's kind of hard to call them one group, even though they might have similar backgrounds, or the way they use the device, where they use the device is similar. So I think you just have to look at, again, what are those characteristics, what are those differences, and how they interact with the product, and then make your rationale based on that.
Yeah, I was gonna say, I think you kind of answered this already, but somebody kind of wrote that if you have 5 to 7 participants per your study, do they need to be different participants or can they be the same? And it sounds like it just really depends on what you're testing and what your justification is.
Yeah, and again, that 5 to 7 is, that's in usability testing in general, medical devices and all sorts of products. 5 to 7 participants, you start to see some of the same issues over and over again. And so that's the point where, if you want to run kind of a quicker study, get data, say what are those low-hanging usability issue fruits, 5 to 7 is a good number to kind of not go overboard in terms of a large scope study, but still getting some meaningful results that you could take and make some revisions to the design.
Okay, awesome, awesome. All right, kind of going back up here. I know we're getting close to time. We'll see what we can get in here. Somebody wrote, prior to the summative evaluation, I presume the formative evaluation used to identify design hazards on usability, which I think we kind of discussed that. That's where you're kind of doing, like you said, the work to just kind of see what are the hazards. Then is the summative evaluation more of a use case evaluation? And do we need to have traceability between these two evaluations?
Yeah, great question. So I think the traceability is important, but not necessarily. I think I mentioned that. So okay, if we take one particular design element, let's say a button being red on a device. And let's say in the formative study, the results come back and we see, a person or a couple of people who say like, yeah, that button shouldn't be red, it should be blue. And what I think is important to know is that you don't have to do that as a manufacturer. Now, again, if you say, because I think the concern is, well, that's in our history, right? That's in our file, this feedback and the traceability. If someone looks back and says like, well, man, you had feedback in there that said it should be this versus that, why did you not do that? And so I think it's just important to know that the formative study should work for you. And if there are no safety implications for this particular thing, the red button versus the blue, it might just be preference. Then take each of those results and use them appropriately. You don't have to justify why you didn't make it blue, and in that case, because it wasn't risk related. And so I think just making sure that the formative study is formal enough that you could summarize it later and make some decisions from it, but not so rigorous that it doesn't actually, that it hamstrings you and makes you nervous to get the results that you might not know what to do with.
All right, I think maybe we have time for maybe one more question. Let's go with this one. In response to the critical task, should those be identified to the users in the summative usability study or just flag them internally? And how many uses get it?
Yeah, great question. So the critical tasks would only be known by the researchers, right? We wouldn't tell the participants. But what we do in the study, again, in that simulated use fashion, we want to make it as realistic a scenario for them as possible. So we would set up, some reason they would be using the product, and say, okay, now, go ahead to accomplish this goal that you would have with using the product. Do what you feel is necessary. They then perform the tasks, and they might include non-critical tasks, things that don't have serious safety implications, and there might be some critical tasks in there as well. But the participants are just using the product as they think is appropriate, and we in the background are scoring their performance on the tasks as they complete them or as they fail them in some cases.
Awesome. Thank you so much. All right. Well, like I said, with that, I think we're at time. So again, thank you everybody for joining us. Bryant, thank you so much. That was really awesome. Just want to thank everybody for hanging out with us. Learned a lot. Very excited about tomorrow. So we have the third day of the virtual summit. It's going to be loaded with content. We're going to include topics such as APAC, Israel, Central and South America, relations with regulatory bodies, and IVDR. I'll be there as well. So again, thank you everybody. Bryant, it's been awesome. And these slides, they will be available on the website. So we'll get some information on that. If you have anything just questions about this, let us know. I don't know, Brian, do you want me to send over some of these additional questions that we had that maybe we can answer as well?
Absolutely.
Okay.
Yeah, if you can, and then the way I can get back in contact with people, I'll definitely answer them.
Awesome. Well, thank you again, and I hope everybody has a great rest of their day.